So, welcome, sir. Thank you so much for joining us today in SYCCON S3, and the mic and the platform is yours.
Yeah, thank you so much, and I hope I'll share my screen now. So, good evening, everyone. The previous presentation, no, sorry, previous thing which belongs to that HEMEX group, right? So, those were the, I guess it's a good initiatives and all those blood campings and medication counseling regarding hematology drugs, all those things were mind blowing actually. So as a clinical pharmacist, I'm really proud. I feel proud that MX is doing some kind of good things in the society. And before going to my slide, I would like to thank RX Doctor and STA for giving me this and good opportunity to present on overview of blood components and its basic disorder, with main emphasis on role of clinical pharmacists in hematology. Okay, so before going to any kind of topic, it's actually needed that it should start from the basics. So basic of hematology is how it gets differentiated. The first thing is the hematopoietic stem cell is the main stem cell which gets differentiated into two type of progenitors. The one is myeloid progenitor and another one is lymphoid progenitor. So these myeloid progenitors are responsible for differentiation of thrombocytes, basophils, neutrophils, eosinophils, and monocytes, along with erythrocytes, a larger amount of blood cells. And this lymphoid progenitors can be classified. It gets differentiated into lymphocytes, which are granulocytes, which contain granules. So they are classified as natural killer cells, T lymphocytes, and B lymphocytes. So I would like to move on with the basics of blood and blood components first, and then I'll move on with the blood disorders. So the first functions of blood, as everyone knows, the blood is a necessary organ for the transport of oxygen and carbon dioxide. So it is very much necessary for all the all the living beings, and it helps in transport of essential nutrients for the tissues which needed most number of nutrients, and it regulates the body temperature through various mechanism, but one familiar mechanism is by vasodilation and vasoconstriction, I guess. So hope everyone knows the mechanism of this vasodilation, vasoconstrictor regulated body temperature. And excretion of waste product. This is one of the major function of the blood. It helps in excreting whatever waste products after many cycles like glycolysis or TCA. So we kind of have lots of biological cycles which been going on in our body, and this blood helps in excreting through kidney or through liver, and it acts as a defensive mechanism. This is a mind-blowing thing which I would like to discuss, because so the WBCs. Actually, I've been recently searching for WBCs
Sorry
and
to
their
interrupt.
mechanism.
Dr.
Sir,
Vishwapal, your
PPT
PPT
not
is not
visible.
visible.
Okay, 1 second. So now is it visible?
Yes,
Yes,
sir.
sir,
Hello?
visible.
Yeah. Okay. So I was talking about this defensive mechanism, and recently I was looking into videos of how this WBCs has been working against a defensive mechanism through an electron microscope, and it was actually a mind-blowing thing where how it captures the cell and how it destroys the micro bugs which is found in our body. So this is a very complex mechanism. And the next one is clotting. The clotting is very much important, I guess. So from our childhood, we would have been playing outside, and if we get any kind of bleed, this platelets comes into the action with the clotting factors, and it helps in clotting. So the first one I would like to discuss is a red blood cell, RBCs, which is um, a larger amount of blood cell which is present in our body, and moving with the morphology, and the red blood cells are biconcave, and which is disc-like structure with flattened center. So you could see this image, I guess, in the slide, which has a flattened center and it's a disc shape. And actually, the red blood cells average lifespan is around 120 days. So in 120 days, it takes 7 days to mature, which is inside the bone marrow, and after that, it gets released in the bloodstream. And this red blood cell doesn't contain any kind of nucleus, and so this is an advantage for RBC that it's fit into any type of blood vessel. So it can be either arteries or veins or capillaries. So capillaries are very thin blood vessels with a small space. So it even can penetrate into it because of lack of nucleus. And this red blood cell contain hemoglobin, as we all know, which helps in transport of oxygen and carbon dioxide. And we have two conditions regarding to red blood cells. One is anemia, and another one is polycythemia. So anemia has a decreased blood levels. So how could you differentiate a patient with anemia or not? So a patient with anemia will be fatigue, and he has some this kind of oxygen deprivation where PCO2 will be higher side. So in rare cases, and polycythemia is where blood clots happen. So this can lead to stroke or any CAD or PVDs. So next is white blood cell. White blood cell, as we have discussed, it helps in defensive mechanism, and this is very much fewer in number. And the most common type of WBC is a neutrophil, which composed of 50 to 70% of WBCs. And this neutrophil lifespan is very much less. It has a lifespan of only a day, or maybe below 24 hours, and transfusion of neutrophil is not effective because of its lifespan. So it lives only for a day, and if you're going to transfuse a neutrophil in a neutropenic patient, it doesn't gonna be as effective treatment in the transfusion. And the next one which I'm going to discuss is lymphocyte, next largest WBC after neutrophil, and we have two types of lymphocytes. One is T lymphocyte and B lymphocyte. T lymphocyte regulates the function of immune cells and kills infected cells. So in case of tumor markers, we could disease like lymphocytes in a high if it so next one basophil. So eosinophil is micro allergic reaction, and it also contains infection. So we have two types of WBC disorders. One is leukocytosis and one is leukopenia. Leukocytosis is where increased WBC count, which is seen in infection. Leukemia, lymphoma, which is an type of cancer, we'll be discussing about this, and immune disorder. So leukopenia is where there's a less number of WBC. So when there's a less number of WBCs, we'll be much more prone to get the infection. So like neutropenic case. So the next is platelets. The platelets are cell fragments. So this is not a type of cells which is present like the RBC or WBC. So it is a cell fragment morphologically, and actually it has a life-threatening function. As we all know, the platelet also is one of the cofactor for CAD or stroke or PVD to occur. And as we discussed before, it is originated from megakaryocytes in the bone marrow, and it gets circulated in the blood, and it is stored in the spleen. So even platelet doesn't have any nuclei, so it has a discoid morphology, which is around 2 to 4 micrometer in diameter. It means the it doesn't have any kind of shape, and it is almost 2 to 4 micrometers. And when hacked to irregular bands spread from it gets spread to irregular branches. So this is how the platelet goes and gets in attached to your. So injured, the platelet its receptor such as P2Y12 gets activated. So when this P2Y12 activates, it decreases adenylate cyclase. So when adenylate cyclase decreases, it suppresses the cyclic AMP formation. And the cyclic AMP, suppressing cyclic AMP activates glycoprotein 2B and 3. This glycoprotein 2B and 3A receptor will attract platelets and gets clogged into it. So this is how the clotting mechanism actually. Uh, it provides space for assembly and activation of coagulation complex and generation of thrombin. So, as I said before, the second slide regarding the clotting, not only the platelet, the clotting factor is also very much important in clot formation. This platelet activates the coagulation complex, and it also, so by activating the coagulation complex, the end product is thrombin. Thrombin forms the fibrins. So fibrins are the clotting agents. So decrease in platelet is called thrombocytopenia, which causes bleeding, and the increase in platelet is called thrombocythemia, which causes clotting. So thrombocythemia, we doesn't see much number of cases, but thrombocytopenia, um, I guess this is a major topic which we have to discuss about. Where there's as a clinical pharmacist, there's a lot of drug which causes thrombocytopenia. So in so we have to differentiate whether the thrombocytopenia for a patient is because of a drug of an disease condition. So differentiating this and managing it would be the better idea, I guess, from a clinical pharmacist point of view. And as coagulation factors, we have two pathways. Hope all PharmD students will be knowing this pathway. This is a very much a simple pathway, where the intrinsic pathway takes place inside your body and extrinsic pathway takes place outside your body. So all those factors, factor 12 gets activated 12A, and factor 9 gets activated 9A. With on this side we have factor 7 it gets converted to 7A, and all these two pathways comes directly to the factor 10, which has a common pathway from factor 10. So factor 10 gets activated to factor 10A, and this factor 10A activates prothrombin to thrombin, and thrombin helps in fibrin. So fibrin helps in clot formation. And I would like to have a quite small discussion on this drugs which acts on this coagulation pathway. And we have warfarin, which acts on 2, 9, and 7. And we have low molecular weight heparin, which acts on 2A, which is on thrombin. And this is I guess this would be a rough idea for how this how this antiplatelets and anticoagulants drugs act on each pathway, each factors. So the next, so from now, I guess we'll be moving on to disease. The basic disorders present because of blood cells. So the first one is iron deficiency anemia. So before moving on to this, I just wanted to say that a clinical pharmacist is someone who has a knowledge about the cause of the disease and the management. Under management, so cause of a disease is almost 30% and other 70% what we have to look into is the management part. So management part, we have a lot of kinetic and dynamics. So I'll discuss about this in the role of clinical pharmacist. So here I would discuss about about the cause and the treatment part where clinical pharmacist plays a role. And for the first one is iron deficiency anemia. We could differentiate the cause into three types. The one is decreased absorption, one is increased requirement, and one is blood loss. And average intake of iron per day from normal being is 10 to 15 gram per day. And in average menstrual bleed, it it's almost 50 ml of blood has been thrown out, and in some patient which is five, which has a greater than 5 times. This can cause iron deficiency anemia, and so so prolonged aspirin or NSAID use can also cause this iron deficiency anemia, because aspirin and NSAID reduces the iron absorption of iron in the body. And from clinical pharmacist point of view, I just wanted to tell that iron is something which absorbs only in the acidic medium, not in your basic medium. So if someone is going to give pan or any kind of proton pump inhibitor or pantoprazole or antacid, and if the patient is going to take iron supplement after that, it doesn't work out. So iron needs acidic medium too, for the maximum absorption. And the oral iron which is being commonly used is ferrous sulfate. It should be given only once a day, not BD or TDS, or maybe 2 days once. This is because if you're going to overload the iron supplement, the iron absorption will be reduced, and for a patient who was on iron deficiency anemia. And to reduce side effect of FeSO4, that is ferrous sulfate, it can be given with food, but still absorption matters a lot. And so I would prefer to give iron supplements before food. And even after the iron stores are replenished, it is better to continue the iron supplements for the next 3 to 6 months. So even so when so failure in therapy, failure in therapy could be because of chloride. So A chloride condition where there's less number of hydrochloric acid in your body. So at that time, you could go with any kind of acid like ascorbic acid, and then you can go with iron supplements. So this so I would so I talked about this oral formulation, and I would like to talk about this parental. Iron extract is not much used, but still, just to give an insight about what can be done as a clinical pharmacist in other ways. That this iron dextran is an high molecular weight, and it should be infused in a longer period. So infusion in longer period causes polyarthritia and anaphylactic reactions too. So to prevent these kind of reactions, and to reduce the infusion time, this dextran has been covered with carbohydrate cell, or its molecular weight can be reduced, and it can be given for 15 minutes to 1 hour infusion. Now, next one is anemia of chronic disease. So anemia of chronic disease can be classified into two types. One is anemia of inflammation, and another is anemia of organ failure. So in anemia of inflammation, so what the kind of uh, the disease which causes anemia of inflammation is like inflammatory disease like IBD, inflammatory bowel disease, and rheumatoid arthritis, and even malignancy can cause anemia of chronic disease. And the mechanism is like inflammatory reaction. Inflammatory reaction is through interleukin 6, which decreases the iron uptake in the gut and reduces the iron transfer from macrophage to progenitor cells. So there is no hemoglobin production happens. So this is how the anemia of inflammation works out. And in this condition, serum iron will be in lower side. So anemia of organ failure. I guess this we could encounter in everyday life. In the condition like CKD, CLD, or endocrine gland failure, we could see anemia. The patient would be around 6 to 7 gram per deciliter of hemoglobin. So this is just because of anemia of chronic disease, and in this serum iron will be in the normal side. So Sorry. Okay. So I said the patient would CKD patient with organ failures would experience anemia of very chronic time. So like so the HB would have been reduced to 6 or 7. So we have to give the RBC transfusion, or else we could give it parental recombinant erythropoietin like epoetin or dabopoietin. So this parental recombinant erythropoietin is used in hemoglobin, which is less than 10 gram per deciliter, and anemia is due to rheumatoid arthritis or IBD or zidovudin therapy in HIV patients. So this is a criteria for using this epoetin. So where HB is less than 10 gram with a condition like rheumatoid arthritis or IBD, zidovudin, and but using this epoetin alpha can risk in VTE. So this must be noted. Um, so next one is vitamin B12 deficiency and folic acid. Uh, Sorry. So vitamin B12 deficiency and folic acid. Why is this in the same slide? It's because most people will most it's really difficult to differentiate folic acid deficiency, or it's because of vitamin B12 deficiency. So I'll say how it gets different, how it's difference between we differentiate between these two. The first vitamin B12 deficiency. Vitamin B12 deficiency is actually because of dietary deficiency. So inadequate vitamin B12 through our food is the main cause of vitamin B12 deficiencies. And the next one is pernicious anemia. As we all know, pernicious anemia is something that intrinsic factor of our stomach parietal cell will be eroded, or it is shrink so that the stomach parietal cell cannot absorb vitamin B12. This is called pernicious anemia. During pernicious anemia, long-term vitamin B12 or lifetime vitamin B12 supplement is necessary, and even gastrectomy. So vitamin B12 normally gets absorbed in your gastric, that is from your stomach. So if gastrectomy is done, sure there's no absorption of vitamin B12. So you would definitely go with vitamin B12 supplement. H. pylori infection can also cause this vitamin B12 deficiency. Even PPAs. So proton pump inhibitor for longer term in the sense more than 2 or 3 months. If a patient is on proton pump inhibitor, they are much more prone to get this vitamin B12 deficiency, because proton pump inhibitor um, which has a mechanism of it reduces the absorption of vitamin B12. And so for vitamin B12, there's only IMO subcutaneous. Sorry, even we have oral route, but IMO subcutaneous is preferred for the immediate action. Oral route takes longer time to act, and under to 1000 microgram IMO subcutaneous with high dose initially, and daily. This would be continued for first week, and after first week, weekly for the next consecutive months, and after the next month it should be continued for a month, continue for a life whenever there is a vitamin B12 decrease in vitamin B12. So next is folic acid deficiency. So folic acid deficiency can be because of either decreased absorption or increased requirement. So decreased absorption is due to the same drugs. So here we play the important role. So medication reconciliation will play an important role in folic acid deficiency. I'll tell you how it plays in the upcoming slide. So the phenytoins, alpha salicin, Bactrim, that is sulfamethoxazole, cotrimazole, sulfamethoxazole combination, and concurrent vitamin B12 deficiency can also lead to folic acid deficiency. So increased requirement in pregnancy or hemolytic anemia can also cause this. And treatment is by oral folic acid, that is 1 milligram, or folate, which is a common brand available, 5 milligram brand daily. Okay, uh, so this is so I before starting this slide, I have mentioned you that there would be a confusion between vitamin B12 deficiency and folic acid deficiency. So the difference between is once when the patient arrives, there would be um, there will be confusion whether the patient is on vitamin B12 deficiency or folic acid deficiency. So the both symptoms are the same, And if you are going to treat only for folic acid, vitamin B12 will be in a lower side, but your HP levels will be increasing. But once when your vitamin B12 is in a lower side, it can lead to so it can lead to nerve damage. So nerves need vitamin B12 for a regeneration. So this can lead to vitamin B12, it can lead to nerve damages. So it is always important to differentiate vitamin B12 deficiency and folic acid deficiency. Next one is hemolytic anemia. So hemolytic anemia, as the name suggests, there's an hemolysis which is sorry, it's a red blood after bone marrow production, because it gets cleaved off, red cells gets cleaved off, and in a faster rate than the production rate, as in the case of osteoporosis. So osteoporosis is where something the destruction is more but the production is less. So the same thing applies over here. And the causes is because of intrinsic and extrinsic defect, or intrinsic is because of hereditary, and extrinsic, which comprises of immunity, or means auto antibodies, or it's because of infections in RBCs. So most of the patient doesn't need treatment for the hemolytic anemia, but in a severe case, eculizumab is given. So eculizumab is an humanized monoclonal antibody against the complementary 5, and this is given for every 2 weeks. So it improves the quality of life and reduces the hemolysis and blood transfusion. But risk of Neisseria meningitis is more while giving it eculizumab. So to prevent this risk, so we are going to vaccinate patient with meningococcal, or you're going to give a prophylaxis oral penicillin. So in case the patient is on allergic to penicillin, we'll be moving on to fluoroquinolones. And ravulizumab is a longer-acting eculizumab, which is given for every 8 weeks, and the side effect of eculizumab it is seen reduced in ravulizumab. And aplastic anemia, which is also a most common case. The failure of bone marrow, which is due to suppression or injury to hematopoietic stem cells. Am I late in time, or am I delayed?
Yes, sir.
Yeah, so I'll just complete it soon. So aplastic anemia, it's where the bone marrow suppression takes place, which is due to injury in radiation or chemotherapy, and because of any other medications like romfenicol, sulfonamides, or phenytoin. So we have epoetin and darbepoetin with filgrastim. Filgrastim helps in increasing the WBC count. So aplastic anemia is where all the cells gets reduced, means WBC, RBC, and platelets are in a lower level. So for RBC, we give epoetin and filgrastim for your increasing WBC counts through TPO, and platelet is, and even the platelet can be given if the platelet is in a reduced side, in a lower side. And acute lymphocytic leukemia. So this is a cancer of blood and bone marrow. This is more common in child than in adult. AL affects lymphocyte from bone marrow. And so the main mechanism over here is lymphocyte does not mature, and it gets crowded and doesn't allow cells to get out and come into the bloodstream. So this can be due to genetic mutation. And neutropenia. Neutropenia is where that is reduce the WBC count, and in neutropenic patient, we'll be giving antibiotic if the patient is on fever, and GCF, granulocyte colony stimulating factor, can be given, and even corticosteroids. Corticosteroids are mostly given in as to increase the platelet or neutrophils. And thrombocytopenia is where the platelet gets reduced, and it can lead to bleeding. So immune thrombocytopenia, it's because of autoimmune condition, and this is caused by SLE or any other medications like heparin. So we would have come across about HIT, that is heparin induced thrombocytopenia. So this can be either immune or non-immune. So HIT, in case of immune condition, so whatever the condition is, if it is because of heparin, you have to discontinue the drug immediately, and the platelet transfusion should be avoided because it can also lead to clotting. So alternative anticoagulants like argatroban or bivalirudin can be preferred, or in such case, if that is costlier, you can move on with fondaparinux. And so I would like to tell about this blood transfusion. So I guess this is very much important for everyone to know about a blood transfusion. So this blood transfusion happens to this helps in increase in hemoglobin. So each unit contains 300 ml, which has approximate about 200 ml of RBC. So each unit of packed cells. So every just to remember, each unit of red blood cell increases hemoglobin approximately to 1 gram per deciliter. And fresh whole blood is not yet being used. Um, so it's not used in the regular time. It's not used now. And platelet transfusion, platelet transfusion is used in thrombocytopenic patient. And as I said, HB level, sorry, while you're transfusing RBC, each unit increases 1 gram per deciliter. But in the platelet transfusion, each unit of platelet transfusion increases about 10,000 cells of platelets. And fresh frozen plasma. So fresh frozen plasma, it is given to improve the so it is a substitute for coagulation factor. And if it is to be given with PRBC in patient patient having any kind of trauma, so it should be given with a ratio of 1:2. So if you're going to infuse FFP with PRBC, so we have to, it should be in a ratio of 1:2. And cryoprecipitate fresh plasma, which is being cooled for 4 degrees Celsius, and 1 unit contains 15 to 20 ml. So these units is very much important. Means the fresh frozen plasma is around 200 ml, and cryoprecipitate contains 15 to 20 ml of 1 unit, which contains 250 milligram of fibrinogen. Right. So that's all about the basic disorders, and the major part is the role of clinical pharmacist. So we are here to know what is our role in hematology, as well as to be frank, that I am not a hematologist clinical pharmacist, but I have went to some survey and I got information from many of my colleagues who are working in different institutions regarding the role. And the role of clinical pharmacist varies from institution to institution. But I guess this kind of conferences would help upcoming PharmD graduates to be clear about their role. So once a patient said me that he needs a care, but not he doesn't need a care. He needs a quality of care. So this quality of care is given through different. So this quality of care is given through multidisciplinary team. So multidisciplinary team consists of a clinical pharmacist who plays a very major role. So he plays a major role from the time of admission to the time of discharge. So there's some article suggest the impact of clinical pharmacy. This article suggests that clinical pharmacist significantly helps in contributing to the effectiveness of pharmacotherapy treatment, reducing the treatment cost and safety of the medication. And another article from ASH, American Society of Hematology, suggests that clinical pharmacist plays a crucial role in managing the regimen, keeping them safe and minimizing side effects. So these two articles mainly focused on the side effects. So I'll just discuss about the side effect. What is the major role of clinical pharmacy in the side effect? So the first one, our role is all around the hospital. All around the hospital in the sense it starts from admission to the time of discharge. So at the time of admission, medication reconciliation is very much important. I guess you would remember that during the acid deficiency slide, I said decreased absorption is due to some drugs. So if a patient is going to represent, admit with any anemia, so the first thing we have to consider is the past medical history. So sorry, past medication history. What is the drug patient has been on? So not only it's a outside factors, even the drug can contribute to the the upcoming problems or the problem which the patient has. So medication reconciliation plays a very major role for clinical pharmacists. So mainly on knowing the past medication history and correlating whether the past medication history has caused the problem for the patient with who has admitted now. So next is identifying the patient allergy. So once when the patient is so if the patient is unconscious, go with the attender whether the patient is allergic to any kind of medication or not. And I guess WHO has given a clear-cut idea of a patient drug allergy, it's antibiotic allergy. And hope you could just visit WHO and find the antibiotic allergy video. It explained very much clear about allergies, what an antibiotic does to the body. So what type of allergies can happen and how to prevent it. So next is medication error. So this is a vast chapter, medication error. So medication error can happen anytime. So it can happen from prescribing till administering. So from prescribing, after prescription, prescribing error can happen at a prescription time. And next is intending time, this ordering time. Ordering error can happen, that nurse is going to order the medicine. And dispensing time, a pharmacy can dispense it has pharmacy can dispense a different drug than mentioned in the order. And administering error. So administering error comprised of many types. So IV incompatibilities or time to time. So there's no following of time to time administration of the drug. So all these errors comes under medication error. So clinical pharmacist also plays a major role here. So double checking is very much important, mainly for hematology and critically ill patient. Um, so if the proper drug is not given to the patient, there won't be a proper outcome. So the proper outcome should be given, and the monitoring is done by clinical pharmacists. So identifying reporting area. So one of my colleague has said that there's a lot of area which can be found because of oncology in the oncology department while using chemotherapy. So actually the physicians are very much busy in treating the patient. Nurses are very much busy in administering the drugs. So no one is aware of this area. So if any kind of area happens, they just have an measures to overcome the ADR, but they don't report it. So once when you are going to report an ADR, this would be documented, and if any kind of reaction happens in any other patient, so they knows the proper treatment to be followed. So identifying and reporting ADR does we play a major role. We actually play a major role in ADR monitoring. And the next one is drug formulary restriction of drug is very much important. Actually, to be frank, I have attended lot of conference, and they were like they said that restriction of drug formulary is very much important. So restriction of drug formulary, what would you restrict when? So what type of restriction is required? So that is where I lost a clarity. After that, I came to know that so restriction of drug formulary is something restricting the generic products. So I'm not into a generic product, but generic products are something which doesn't check for its bioavailability. They check only for the bioequivalence, and those drugs can cause any kind of side effect because of the particles which is present inside. So so restriction of drug formulary to manufacturers who are very much standard is a necessary thing in an hospital, in any kind of institution. So educating educating patients and caregivers. So educating regarding the medication what they are taking is very much important, because this generation people is nonetheless care about the medication. They don't take medication, they skip medications, and because of their job profile. And so it is very much important to stress the importance of medication. And if they're going to experience any kind of adverse effect because of that medication, it should also be said, because certain patients' mentality is where, if, for example, if a patient is on rifampicin and patient is experiencing an orange color urine, definitely the patient would stop if you're not going to educate a patient about the orange color urine. So stopping the anti-TB drug in a particular time, it almost causes isoniazid and rifampicin resistant strains. So CME to healthcare professionals. So healthcare professionals, since all the pharmacists, all the nurses, all the physicians, uh, continuing medical education is very much important, and audits the major part. Again, the audits are very so we play a major part in prescription audits. As I said, while auditing, we'll find many number of medication errors. So these medications errors are resolved by giving CME case reporting. So one of our major job, case reporting. As I said about reporting areas, case reporting is the same thing which I've discussed in the area. So case reporting is also an important thing, so that this gives an clear insight for your colleague who works in other institution to manage the situation which he or she had never seen. Okay, so I would proudly say that we are PharmD graduates or clinical pharmacists are experts in pharmacotherapy when compared with other professionals, because we know so we are going to check the appropriateness of medication. We are going to do the drug interventions. So drug intervention appropriate medications are only uh, seen through the proper knowledge of pharmacotherapy. So so in the upcoming slide, I will just discuss about certain real-time interventions which is being done in our hospital. So drug intervention. So for those interventions to be done, we should have a clear-cut idea about all the drugs which you are going to be facing every day in an everyday scenario. And the next one is drug-drug interaction, which can be seen with theoretically there are so many drug interactions can occur, but practical is very much important. So I have encountered lots of drug interaction theoretically, but practically I would say very few drug interaction has been. I've seen very few in drug interactions. So when you see any kind of interaction, just correlate with the patient condition, and then if it is necessary, you could inform the physician, and those drug can be changed, or it can be stopped, or it can be withheld. So IV incompatibility. So I would like, so in the upcoming slide I would discuss about IV incompatibility with RBC transfusion and dilution and infusion. So this was something which my colleague has said they were doing in the institution. So dilution of chemotherapeutic drugs or any other any other drug is done by clinical pharmacists, but I suggest that dilution, uh, the information regarding dilution can be shared, but dilution, I'm not sure whether it should be done by the clinical pharmacist. But we have to know about, we should have a gross idea about the dilutions and infusions. So in the dilution, if a patient is on renal failure, or if a patient is having EF less than 40 or 50%, you can't give much amount of much amount of fluids into the patient. So where dilution plays an important role. And in case of in case of time dependent antibiotic, if you are going to prescribe in a in case of time dependent antibiotic, if you are going to prescribe, if the doctor has prescribed a BD dose, and it should be the concentration of this time dependent antibiotic should be at least above the MIC. So if the healthcare professional is going to follow the same protocol, that is if they're going to infuse for 30 minutes alone, it doesn't work out. So the infusion time should also be increased in such scenarios. So in case For example, meropenem. So meropenem, almost in every institution they're infusing for 30 minutes. If it is given, yeah, if it is given as tedious dosing, that is 3 times a day dosing. But if in case of renal failure, if a doctor reduces the dose to BD, the time should be around. It should be a long-term infusion, that is from 1 hour to 1.5 hours. Infusion is necessary to maintain the concentration above MIC. So TDM, therapeutic drug monitoring, is very much necessary in the chemo drugs and side effect monitoring. This is very much elaborated, and so I am highlighting this because so all the healthcare professionals like nursing, the physicians will know, or pharmacists will know the mechanism of action very well, the indication of the drug very well, but the side effect, only the clinical pharmacist will be studying about the major side effects and the probable side effects. So whenever any drug is given to the patient, if a patient is experiencing any kind of adverse event, look into whether the patient has so these drugs could look into a drugs, whether any of the drug causes side effect. If in case the drug has caused side effect, based on risk benefit ratio, whether you can decide that this drug can be stopped or it can be changed, or any other supportive measure is necessary. So also the modalities through which patient is complaints, it's also been done. And therapeutic drug monitoring is something like the drug should be between the therapeutic range, that is it should not be below the subtherapeutic level and should not rise above the toxicity. And therapeutic drug concentration, if it is too little, no effect. If it is too much, it causes toxicity. And TDM for some common drugs is being listed here: antibiotic, aminoglycosin, vancomycin, antileptic, carbamazepine, and phenytoin, immunosuppressant, cyclosporin, and tacrolimus. And for TDM of cyclosporin, before going to TDM of cyclosporin, we'll be checking trough and peak levels in TDM. So for certain antibiotics, we'll be checking peak and both peak and trough levels, but most of the drugs we'll be checking only the trough levels. Okay, for cyclosporin, this is a trough level, and for trough level collection, the sample should be collected either 12 hours after the drug has been infused or just before the next dose administered. So these are the real-time intervention that is being done in our hospital. The one is the first case description is patient with febrile neutropenia was found at a culture report of Klebsiella pneumonia, and the patient on IV imipenem cilastatin 500 milligram every 8 hours was prescribed. But intervention what we made is imipenem cilastatin 2 to 3 gram per day is required, so the dose changed to 1 gram in every 8 hours. So next is drug-drug interaction. The patient was on VF, that is ventricular fibrillation, and was started with ivabradine and ondansetron was going on previously. And the 12-lead ECG showed patient got QT prolongation. And this QT prolongation was due to ivabradine and ondansetron. So these two are totally contraindicated drugs, which they should not be given together. So in case of ondansetron, you could go with any other 5-HTP receptor which doesn't cause any QT prolongation, or you could stop the medicine if the patient doesn't have any kind of nausea or vomiting. And the next one is this is something interesting case where patient with malaria had a low protein and albumin level, and he was prescribed with artesunate, and he developed ARF, and bilirubin levels were also increased after prescribing artesunate. So the major intervention is that artesunate is highly protein bound. So the patient albumin and protein levels are very much lower side, so it doesn't have any binding of protein. So it gets accumulated. It was accumulated in the body, and it has caused acute renal failure and bilirubin rise. And so next one is drug substitution. Linezolid was started in a patient empirically, and it developed thrombocytopenia. And the major side effect of linezolid is thrombocytopenia. So it causes reversible thrombocytopenia. So a drug was stopped, and teicoplanin was added, which has the same kind of the same activity. And the next is disease contraindication. So disease contraindication where the therapy part plays more here. So patient with peripheral vascular disease and coronary artery disease was on ciprofloxacin, which is an antiplatelet. So cilostazol is actually contraindicated in cardio patient, and it can lead to, if it is prescribed, it can lead to mortality, increased mortality. So it was stopped. So IV incompatibility with blood products. So no medicine should be added or infused together with the blood products. So if any kind of medicine to be given with the blood product, the IV line should be stopped, and it should be flushed, and then the other drugs can be given. So only thing which is compatible is 0.9% NaCl. Other than that, you can't give any kind of anything through your blood products. It's because if a patient gets a transfusion allergy or drug allergy, it is difficult to differentiate whether it is because of blood transfusion or because of the because of the drug. So glucose containing fluid, it should not be given. If it is given with a blood product, it causes clumping of red blood cells. And calcium containing preparation, it should also not be given. It reverses the anticoagulant citrate activity and causes RBC to clot. And the final one is antimicrobial stewardship. This is the resistance has been spreading almost all over the world because of not proper using of antimicrobial. And as a so moving on, so in the hematology department, it is very much to it is as a clinical pharmacist, it is very much important to have an antimicrobial stewardship, because the most of the patients who are anemic have anemic or neutropenic have tendency to get infection. So it is best to it's a best practice to have a hand hygiene to the patient. And hand hygiene should be encouraged in all the healthcare professionals, mainly to the nursing staff who are in direct contact with the patients. um, so it's actually time, I guess. And this is the last this is my last slide. And so IDSA, so Infectious Disease Society of America, has several guidelines, and I would like to show one guideline about neutropenia. So this IDSA guideline says that in neutropenic patient who receives who are febrile should be empirically treated within 1 hour of the triage. Because in 1 hour, if the patient is febrile, the antimicrobial should be started empirically at 1 hour of triage. So what type of antimicrobial is given is oral fluoroquinolone with amoxicillin or calvulate. In case of penicillin allergy, clindamycin can be given as empirical therapy. So this is a small example of how the IDSA guidelines gives an clear insight of the antimicrobials used in the hospital settings. And take home message: it is very much important to know about the past medication history, and our work is not at all limited, and we have much more to explore. And main thing is, as a student, we have to know more about our kinetics, dynamics, and side effects. So these three things is the only way we are going to excel in our profession when compared with other healthcare professionals. So full-fledged AMSP is very much important in all the institution, and interaction with healthcare professionals and patients is very much needed. Thank you.
Thank you so much, sir.
Any
Time may
question?
be restricting.
Yeah.
Yeah, but it wasn't restricting us from listening to the knowledge you shared. Any questions from the audience side can be shared now?
Yes, sir. Sir, here I am. Hello, sir.
Yeah,
My
yeah,
voice is clear.
yes.
Yes, sir.
Yes,
Sir, I
yes.
am Dr. Anurag,
Great.
and sir, sir, my question is, sir, how to therapeutic drug tapering in blood? Any protocol is available? So please share. Because, sir, I started recently reversible program via functional and therapeutic plant-based medical nutrition in thalassemia patient and children's. So some research are recently research for some patient, my nearby patient also reverse. But sir, some hematological drug taking patient is not reverse. So I think some drug tapering is important. So sir, any protocol available? Hello, sir. Hello. Hello, Dr. Srisha. Hello.
Laptop connection was lost, I guess. Can you come up again?
Okay. Yes, sir. Yeah. Yes, sir. My question is, sir. Hello,
Yeah.
sir.
Yeah, I'm
Sir,
hearing.
my question is, ki, sir, any drug tapering method in blood drugs? Because, sir, I recently, I started a health reversal program by functional and therapeutic plant-based medical nutrition in thalassemia. So, sir,
Okay.
thalassemia drugs, some child and some patient taking hematological drugs. So, reversal program is not good result or immediately tapering blood related drugs. So fearing and some hesitations because children's and patients, so some side effect, withdrawal side effect is also going. So, sir, what to do? Any tapering tapering methodology? Any available,
Yeah.
sir?
So what would I suggest is instead of tapering the blood products, means blood related drugs like epoetin or something like that, you could extend an infusion time. You could reduce the dose and
Yes.
increase your frequency so that the side effect of the drug would be reduced, can will be reduced. So if you're going to expose a drug for drug with a concentration more in your blood, it causes side effect. So
Yes.
in that situation, if you're going to reduce the dose of the drug, and based on your T off, if you're going to give a medicine with the longer with uh, with increased frequency, it could help the patient to overcome the adverse effect.
Okay, sir. Yes, sir. Yes, sir. Yes, sir. Some article are also showing the same, sir. So I practicing. Yes, sir. I try some with consult with you, sir. In future, any patient comings, and then I with consult with you, sir. Also.
So any other?
Thank you. Yes, time
Thank you.
is restricting, so we could stop here. Thank you so much, sir. That was really wonderful and enlightening for us. Thank you for joining with us. And now, moving